So next company to present is Hansa Biopharma, and with me today I have the head of IR, Claus Sindal. Please, Claus, carry on.
Thank you so much for the introduction, and thank you so much for having me. Very excited about presenting here at your life science seminar. So before I continue, I just need to show this forward-looking statement. So those of you who are not very familiar with Hansa Biopharma, then we are commercial stage biopharmaceutical company. We're based out of Lund in the southern part of Sweden. And we have operations in Europe and the US. And we got our first approval within kidney transplantation for highly sensitized patients. We have a validated technology which has been validated in 3 areas. So first and foremost, of course, with the approval in conditional approval in Europe. Secondly, we also have proof of concept in the first autoimmune indication, namely anti-GBM, where we have now started a pivotal phase 3 program. And then thirdly, we also have 3 partnerships now in gene therapy, more recently with Genethon, and we will also be starting a first clinical trial with Sarepta in Duchenne muscular dystrophy later this year. We have a broad clinical pipeline, mainly within transplantation and autoimmune indications. But as I said, we have also now moved into gene therapy, as well as we also have started our first phase 1 program with our second generation enzymes for repeat dosing. We have a high performance team here in Lund, or actually globally, with a strong tenure, so around 20 years of average life science experience, and we have a very purpose-driven culture. Financially, we are listed in Stockholm on Nasdaq, and we are financed into 2025. End of the second quarter, we had cash of roughly $110 million. We have roughly 20,000 shareholders, and foreign ownership constitutes to roughly 43%. So the company is based on a very interesting and unique antibody cleaving enzyme technology, which very fast and effectively can cleave IgG. And this is relevant in a number of different situations, such as transplantation, to enable transplantation, or to stop an immunologic attack caused by an autoimmune indication. And imlifidase can take down or knock down IgG very fast and effectively. So basically, from a 15-minute infusion, you have 2 to 6 hours afterwards, you have more or less taking the IgG level down to below detectable level, and that will sustain here for 5 to 7 days before it gradually starts to grow back again. And this is the window where you can enable a kidney transplantation. If we look at our pipeline, we have a very broad pipeline with now 7 ongoing programs in clinical stage, including 3 programs in late stage development, namely the European post-approval study, and then also a pivotal study in kidney transplantation in the US, as well as anti-GBM, a pivotal study in this autoimmune indication. If we move into kidney transplantation, Idefirix got a conditional approval in Europe for desensitization treatment in so-called highly sensitized kidney transplant patients. And we got approval based on 4 phase 2 studies where we showed 100% success rate in enabling kidney transplantation in 46 patients. And in kidney transplantation, roughly 10 to 15% of patients are so-called highly sensitized due to a high level of donor-specific antibodies, and that can be the reasons can be multiple pregnancies, it can be blood transfusions or previous transplantations. So up to these 10 to 15% of patients have a very hard time in identifying or finding a matched donor. And looking at the wait list and in Europe, you have roughly 170,000 patients combined, and that would translate into something around 17 to 25,000 patients which would be relevant as highly sensitized patients. But still, organ is a limiting factor in transplantations, as only 1 in 4 can actually get transplanted. So if you look at it on an annual basis, we say that 4,000 to 6,000 patients across Europe and US is the addressable market for us, and we will then take a certain market share of this. We already have the first patient experiences with the Idefirix commercially. We also had, of course, the 46 patients in the clinical trials, but these patient cases, have now been published by select hospitals, and we have 2 cases here I want to mention. So in Barcelona, we had a 54-year-old male who successfully got transplanted in Barcelona, and he had actually been on dialysis for 38 years, and he had 2 failed transplantation attempts back in the 90s. And he's actually doing good today after transplantation. Then we also have a case report from the Netherlands, where a 29-year-old lady was transplanted at the Erasmus clinic in Rotterdam after being on dialysis since 2016, and she was actually born with kidney disease, and she had 2 graft failure or 2 graft losses after she has been transplanted. But with the imlifidase, she actually got transplanted successfully and is also doing good today. So we have received conditional approval a few years ago, and we have been using the last couple of years in building the foundation for our Idefirix, since this is a transformative new therapy for highly sensitized patients. And today, or until today, there's not really been any therapy who could really deal with these high difficult to transplant patients. So we have started to target leading transplantation centers in Europe, started these commercialization activities in early launch countries, and we have now secured market access in 13 markets today, including the 5 largest markets, so UK, Germany, Spain, Italy, and France. We have also ensured that these clinics are ready. They are clinical ready to take on patients. We have engaged with a high number of KOLs across the transplant sector. And more recently, we have also seen that medical guidelines have been implemented in a number of markets, which is very important to establish a good process, identification of patients and how they should be treated going forward. Then we have also seen that allocation systems have adapted to our technology. So more recently, Eurotransplant has allowed for a specific imlifidase tier of patients to be treated. And they will start off with a pilot program, which I will cover on the next slides, initially targeting 20 patients. And we are very satisfied with that, because it's been difficult to allocate organs to these patients in the past because of the high level of donor-specific antibodies. So as you can see on the lower graph, we are approaching now the end of the first phase of our commercializations, which is this phase where we have guided growth to be low and volatile between quarters, because clinics were focused around having the first successful transplantation. So we expect actually more accelerated growth going forward, also as we expand internationally and as we complete the post-approval study. So please remember also that we have been asked to do a post-approval study in 50 patients, which to some extent will limit the growth rates until completion, and it's set up to be completed in 25. And then we also work on the US, where we are aiming on a BLA and commercialization within the next couple of years. We are doing a pivotal phase 3 trial in the US market. Further down the road, we are looking at potential label expansion into living donor transplantation and into other solid organs. As I just mentioned, we have just seen that Eurotransplant has recently initiated a new desensitization program for imlifidase eligible patients. And up until now, there has been an acceptable mismatch project program allowing for highly sensitized patients to be transplanted as long as they were compatible. But since imlifidase also allow for transplantation for incompatible transplantations, there has been a new program been implemented, a new pilot program, which has certain criteria that the donor should be below 65 years old, and also that the patient should have waited on the wait list for at least 3 years on an organ. Eurotransplant is one of the largest, if not the largest, allocation system in Europe, and covers 8 countries, namely Benelux, Germany, and select Eastern European markets. So in total, it covers an area of 137 million people. Beyond Europe, we have also recently received provisional approval in Australia, and this is actually the first market to approve the use of imlifidase or Idefirix in transplantation, both for living and deceased donor transplantations. So this is the first time we actually get living donor on the label. In Australia, the market is actually quite interesting, since 15,000 patients suffer from end-stage renal disease and actually receive dialysis today. Roughly 1,300 patients are waitlisted on the kidney transplant waitlist, and annually Australia do around 850 transplantations in kidneys. But what is also more interesting when you look from a Hansa perspective or imlifidase is that 21% of the patients waitlisted actually have a CPA score of 95 and above, which means that 95% of the organs offered would actually be a poor fit. So this is actually where we can come in and address the market. So this is, first of all, a provisional approval. Full approval in Australia will still be dependent on data points from the long-term follow-up data or study, as well as the post-approval study in Europe and the US ConfIdeS study. If we move into the autoimmune disease space, then autoimmune diseases hits roughly 3 to 5% of people globally, and it's most times it's triggered by a virus or a bacteria, which triggers the immune system to attack the body's own organs, and in many cases the lungs and the kidneys, which is relevant for us. So there are more than 100 different types of autoimmune disorders. Today, the vast majority of these are chronic, and then roughly 10% are acute, which is what we will be able to address with our technology, which is for monophasic single-use treatment. And if we zoom in on some of those areas where it's relevant in the autoimmune space to use our drug, then we have 3 ongoing programs. First and foremost, of course, anti-GBM, which is already in a phase 3 program. And then secondly, we have GBS, or also called Guillain-Barré syndrome. Those 2 programs have been going on for a while ANCA-associated vasculitis is a complete new indication, which we have actually started here in July, started by an investigator in Berlin, Charité. And if we should zoom in on this new indication in ANCA-associated vasculitis, then it's a very interesting indication, as it's IgG antibodies which flows in the bloodstream and causes damages to the blood vessels, which eventually gives or end up in inflammation and will damage the kidney and sometimes also the lung. So the incidence is roughly 3 cases in 100,000 annually, and for those cases, who have acute respiratory disease distress syndrome. It's the thought behind this study that's our target population. So in this phase 2 study, we will target 10 patients, and we have already started to recruit these patients. And we will look for safety and efficacy here in the first phase, and then we will do an evaluation on the path forward. So it's sponsored by Charité, so there's very little cost associated to Hansa for this study. If we move on to this very exciting area of gene therapy, Hansa has 3 partnerships, and namely with Sarepta Therapeutics, but also with AskBio and Geneton. So in gene therapy, we know that neutralizing antibodies is a immunologic barrier in gene therapy, as they prevent gene therapies to be transferred into the patients, because these vectors which are being used are so-called associated adenoviruses, and it's not possible to transfer the healthy gene in and replace it in the cell with today's treatment. But the thinking here is that we can eliminate that barrier with imlifidase, and we have shown that preclinically, and we expect now to move into the clinic with Sarepta. So this is just to highlight those 3 programs we have, or 4 programs we have with 3 different partners, and the most advanced is within Duchenne muscular dystrophy, where we have moved or will move into the clinical phase this fall. Just a brief slide on Duchenne muscular dystrophy, which affects roughly 1 patient in 3,500 to 5,000 birth, and 14% of these patients would have pre-existing neutralizing antibodies to these vectors, which is why we are investigating this together with Sarepta. Patients are typically diagnosed at the age of 3 to 5, and this is also within the space where Sarepta got approval. And most of these patients would be sitting in a wheelchair at the age of 12 to 15 and die at the age of 25 to 30 years. So in essence, Hansa is a platform. We have 4 different spaces we can address. So transplantation, autoimmune indications, gene therapy, and oncology. We have 2 technologies. We have first generation antibody cleaving enzymes for single use in monophasic diseases, and then we have also advanced our second generation enzyme for repeat dosing into the clinic this year. So with that, I'll hand back to the moderator.
Thanks a lot, Claus, for a really good and in-depth presentation of Hansa. And to the audience, we open up for questions now, so you're more than welcome to post some questions. But Claus, I could probably start with one question here. Why is it that Idefirix or imlifidase is so superior compared to today's plasma treatment?
So it's a very unique mode of action we have with imlifidase. So basically, from a 15-minute infusion, you can knock down all IgG in the body within 2 to 6 hours. That's not possible with plasmapheresis or any other technologies today, not even the FcRn inhibitors. So it's a very effective drug. It's very rapid in its action, and it sort of cleaves all IgG, both in the bloodstream and in the tissue. This is very unique because some of the approaches in today's healthcare is only cleaving or is only removing or reducing the IgG in the bloodstream, but not in the tissue, for instance. And you will never ever get down to these levels we can prove or demonstrate.
Thanks a lot, Claus. And autoimmune diseases is not like something new, but to treat them is really new. Do you feel in Hansa that the regulatory bodies, FDA, EMA, possess the right infrastructure and insight enough to to treat you the right way and other companies in this show?
That's a very interesting question, but eventually it comes down to the data and what you can demonstrate. Of course, I mean, when you engage in a new study, you also try to clear off, of course, with the regulators on the path forward for a potential approval eventually. Right now, we have demonstrated in anti-DBM, for instance, very superior data showing that 2 out of 3 patients will become dialysis independent and in general do good, versus today's standard of care, which actually shows the opposite, that 70% of the cases would end up in dialysis or even die, right? So I guess it comes down to the data and the unmet medical need, right? But we are in this market for positioning or targeting rare diseases, IgG-mediated rare diseases.
Good. And is there any reason why you've chosen GBM, GBS, and AMR as the first indications?
Anti-DBM is I mean, it's almost a model indication. I mean, if monophasic, it's acute. I mean, where a single treatment would allow for a big effect, right? So this is the thinking that we go for those areas where you would like to see the best outcome, right? As I said, it stems from a human pathogen, so it can only be used once. So we need to be very diligent around, which indications we pursue.
Thanks a lot, Claus. If there's any questions out there, please post your questions and I will forward them to Claus. But I could ask one more question here. Idefirix is approved in Europe, and have you seen any kind of off-label use in patients with other types of autoimmune diseases, Claus?
Of course, it's not something we proactively can promote or discuss, right? But there are some hospitals who, I mean, we see significant interest for our compound because it's so relevant in many different spaces. So there has been used. It has been used in the past in some indications, right? But of course, it's up to the doctors to also decide on that, and it's not something we are very engaged on. Of course, there are some compassionate use, etc., some specific programs, but in general, we try to limit our talks and dialogue around, where we got a label.
Of course, and focus on what you know as of now. There's not any other questions coming in right now, Claus. If there's coming any questions afterwards, I will, of course, as always, mail them to you. And with that said, I really appreciate your attendance today. Thanks a lot for a very good presentation, and enjoy your day.
Thank you so much for interest.
Thanks a lot.